Hello, everybody. Thank you so much, everybody who's joining us for this webinar, which is part of our series of presentations that is being delivered on applying evidence in practice as part of the Comorbidity Project, which is being funded by the Australian Government Department of Health. My name is Christina Morell. I'm a Senior Research Fellow and Program Lead of Treatment and Translation in Complex Populations at the Matilda Centre for Research in Mental Health and Substance Use at the University of Sydney. I had the very great pleasure of facilitating this webinar, which is being presented by Dr. Robert Fullerton. I would first like to acknowledge and pay my respects to the traditional owners of the lands on which we're meeting, and of course recognise that we are all meeting across Australia. The traditional owners of the lands that I'm currently on are the Gadigal and Wangal people of the Eora Nation, but I would like to also pay my respects to other traditional owners of the lands across Australia for everybody who is here. I'd also like to recognise and acknowledge many people with lived experience of mental illness and substance use, as well as their families and carers, many of whom have so generously contributed to the development of the comorbidity guidelines and other resources. Everybody here is probably very familiar with Zoom, but just to quickly go over a few things before we begin. First of all, to let you know whether you're attending live or watching the recording later, of course, that you are in listen-only mode, so we cannot see or hear you. So I would just like to draw your attention to the Q&A and chat buttons on your screen. If you haven't located them already, please feel free to click on those buttons and type in any comments or questions that you have during any time during the presentation. We will be having some time at the end of the presentation for discussion, and we'll go through those. If you have any technical issues during Robbie's presentation today, you can contact Zoom support, or you can access the recording of the webinar, which we will be making available, as well as the PDF handouts of the slides. Those will be available to download from the website on your screen there. So we have an exciting series of webinars over the next few months. And thank you very much to those of you who have given us suggestions for future webinars in our end of webinar survey. We do ask for suggestions, so please let us know if you have any topics that you would like to see as part of this series, and we'll see what we can do. Today's webinar will be focusing on motivational interviewing, guiding clients to make beneficial changes, but you can find out more and register for our upcoming webinars at our website, which I've posted on screen there. And now, of course, it's my very great pleasure to introduce Dr. Robert Fullerton, who is an Associate Clinical Psychologist at STNA Psychology, Clinical Supervisor and Clinical Director of Feel the Magic, which is a charity that supports grieving children and their families. He holds a dual PhD in Clinical and Industrial Organizational Psychology from the California School of Professional Psychology and has 12 years of experience applying motivational interviewing in government-funded university counselling and private practice treatment settings. So we're very lucky to have Robbie here today, and I will hand over to him to get started. Thank you so much, Robbie.
All right, thanks, Chris, and thanks for having me. Today, I'm going to be talking about motivational interviewing and how we're going to guide clients to make beneficial changes. So the learning objectives today are going to be understanding the Transtheoretical Model of Change, getting a sense for what motivational interviewing is and when it is useful, and gaining some knowledge of what the spirit and the principles of motivational interviewing are. And by the end, hopefully you will have learned some core communication skills of motivational interviewing that lead to behavior change. So first of all, I'll be discussing motivation. Motivation is a very strong predictor of change. A lot of times you'll notice that the best type of motivation is intrinsic. You can't really force people to make changes. They have to want to make changes themselves. And I know that can be very frustrating when you think you know what's best for them and you don't see them making the changes that you're recommending on their own volition. However, when clients are motivated, you'll notice increased participation in treatment, which can yield positive treatment outcomes. It's important to think about desire to change on a continuum. So it's a continuous rather than a dichotomous variable. It's not like you're either really motivated to change or not at all. You'll fall somewhere within that continuum. And as practitioners, we have to stay very attuned to where that client is with respect to their desire to change and how motivated they might be. Ultimately, the practitioner and the patient will both contribute to the patient's motivation to change through the therapeutic partnership. And so you may notice that little quote at the bottom of the slide from Stephen Covey, who a lot of you may know from 7 Habits of Highly Effective People. And it says, motivation is a fire from within. If someone else tries to light that fire under you, chances are it will only burn very briefly. This quote just illustrates that it's not just about us lighting a fire under our patients. More to the point, we need to figure out ways that we can ignite that fire from within the client to make them want to change. So why are we even talking about motivational interviewing? Well, it's been shown to be very effective in a lot of different areas of changing behavior to improve health. So this is a long list of controlled studies where it showed efficacy. So again, substance misuse, drug and alcohol, smoking cessation, medical compliance, maybe HIV risk behaviors, changing diet and exercise, oral health maintenance. And then at the bottom there, I just have a citation of a really important meta-analysis. So it's a motivational interviewing, a systematic review and meta-analysis that found that motivational interviewing is significantly better than other approaches in 3 out of 4 studies that were examined in this meta-analysis, which I believe was a sample of 72. And it outperformed traditional advice giving 80% of the time. Now, I know that sometimes when we're talking to clients about why they should make changes and what we think they should do to make those changes, it comes off as here's why you should be motivated, or why I think you should be motivated, and then what you should do about that. But that's really just advice giving. I'll talk about how that differs from actual motivational interviewing in a bit. Also part of this study, they found that brief encounters of just 15 minutes or less in 64% of studies showed lasting effect using this method. So sometimes I'll do this presentation with general practitioners because they have limited time with clients, but that figure does show that even with a short period of time with a client, you can make some lasting change. So what do we bring to the table when we're practicing motivational interviewing? Practitioner would have to be empathic, have a warm disposition, and just be very genuine with the client. Just try to really be yourself with the client. Empathy is defined in a lot of ways, but the creators of motivational interviewing have defined it in this way. So you show empathy through the skillful reflective listening that clarifies and amplifies a patient's experience and meaning without imposing our own material onto the patient. So I know this kind of goes against the grain with a lot of the things we've been taught to do or we want to do. For instance, it's very tempting to tell people you need to make this change and here are all the reasons why. And I think a lot of us have had that experience of trying to get people to change, genuinely having their best interests at heart, but not seeing them make the difference because we're really just imposing our own agenda onto them rather than exploring and walking with them in what that struggle is and how to get through it. So it's clear what steps they can take and want to take in order to make that change and why they're motivated to go down that path. A really important concept in motivational interviewing is ambivalence. One of the things that prevents people from changing is this natural ambivalence that comes with needing to make a change. There's a reason people don't easily change. We do get kind of ingrained in our habits. We're at the same time motivated to change for some certain reasons that we might tell our therapist, but we're also heavily motivated to not change at the same time. So you can see this kind of is illustrated in this seesaw. So I can see that I want to change for these reasons, but I feel really stuck and I'm kind of in the habit of doing some of these things and I'm motivated to not change. Now, if a patient's in front of us and you see they're engaging in some behaviors that are compromising their health, or you see they have risky substance use, and that is really negative consequences for them, you can point out all the negative things and all the things that maybe even themselves know are reasons for change, but there's a whole host of things counterbalancing that. there may be a source of comfort in using. Maybe it's all they've ever known in terms of trying to cope with difficult situations. And those are things motivating them not to change. And that's what we're really kind of up against with a client. Fundamental to motivational interviewing is to acknowledge that ambivalence is a natural part of going through change. And rather than just weighing down the one side that says you need to change because X, Y, Z, it's important to look at the whole picture and try to understand this together, and then figure out what you're going to do with that. What we really want to avoid is speaking in a way that is judgmental, moralizing, shaming, commanding, or even threatening to get our client to do what we want them to do. It's more of a sense of let's understand where you are and what you're going to do with that. So a lot of people probably have seen this diagram, but this is part of the Transtheoretical Model of Change, and it reviews the stages of change that are put forth by Petresca and Di Clemente. In order to move people from not wanting to change to wanting to change, we need to understand the various stages, if you will. It's not a perfect stage model because it's not thought to be linear, but it does include different stages they may be going through. So the first at the very top would be pre-contemplation. That's not really having any intention to change. They may even be in complete denial that they have a problem, and they may not want to acknowledge it. Secondly, you have contemplation, in which they're aware that there's a problem, but there's no commitment to action. So they kind of think, oh, I could change, but it's easier to stay the same. But I'm thinking about it, hence the name contemplation. Then we have preparation. They're intent on making a change, but they haven't quite taken action yet. But they're on the precipice of doing something. And then we have action. So this is when they actually do something about it. They're committed to changing and they're taking steps toward that change. Once they've taken action, we want to see them maintaining that change. So the next stage is maintenance. They've taken steps to change, they've noticed some results, and they want to continue doing that. Your job at that point is to support them and try to help them maintain progress, as well as do any type of relapse prevention. So that brings me to relapse. I prefer to use terms like lapse or recurrence. Relapse is a bit has some negative connotations to it, but we're trying to look at lapse or recurrence as a natural part of the cycle. We should highlight this because patients can easily get disappointed in themselves if they slip up, and shame can be a really detrimental part of the process if they're trying to make change. If you normalize that at some point a lapse may come and it will be part of their journey, then there's a lot less shame involved in the process. And really, we want to look at it as a learning experience. And a lot of times what we'll do is take that opportunity to acknowledge how far they've come to get to that point, and highlight all the things that they've done, not necessarily just that they've had a bit of a slip at that moment. So I'm going to go through each of these stages just to give you a flavor of them in more detail with some examples. So again, pre-contemplation is not really considering change, little awareness or concern of the negative consequences, maybe even a bit of the defense mechanism denial. An example of what a client might say to you is, my blood pressure readings have been a bit high, but I feel fine, so I don't think there's a problem. No motivation to change there. They don't see that there is a problem. In contemplation, they consider change, but they kind of reject it. They might still be in the grips of that ambivalence, and they seesaw between reasons to change and reasons to stay the same. So an example of that would be, I can see that it would be better for my health if I quit smoking, but it's my only break in the day when I can get some quiet alone time. So here there are valid reasons why they would change, but there are also reasons that they would want to stay the same. It serves a purpose. And a lot of times you'll find it can serve a need, like, you know, there's a need to have a break in the day or have some comfort. And it's really hard for them to break that up, especially if they don't see an alternative for it. Preparation is that window of opportunity when you see that the balance has tipped on the side of wanting to make a change rather than being an ambivalent. It's really about what action steps that you can take and what resources you can get around the client in order for them to move toward that change and take action. So an example of what you might hear clients say is, I really want to lower my cholesterol. I just don't know how to go about it. Perfect opportunity. There's the desire to change. They're just not quite sure how to go. Action is when they've actually decided, I'm going to make some steps toward change, and they're willing to engage in particular behaviors designed to bring about the change. You may have offered suggestions and they've pursued them and acted upon them. It may happen with or without any of your assistance. The key is there's determination to produce a change in that area. One of the things you might hear clients say if they're in action is, after our last visit, I actually did book in to see the psychologist for my anxiety, like we talked about. Maintenance. This is where you're just there to try to sustain the change or continue the actions that they've committed to. Part of maintenance, like I said, is also relapse prevention. And you want to be affirming the actions that they've taken and making sure they're staying on that path. A client in maintenance may say, the last few months on these medications have helped, but I'm wondering if I really need to keep taking them. You hear this a lot with some clients that maybe are enjoying the benefits of some change, but are ambivalent about whether they want to keep applying the effort to maintaining that change. So here's a good opportunity to really highlight what they need to do to sustain those changes. But you can still see a little bit ambivalence around, the difficulty in doing that. Again, lapse or recurrence, it's really important to normalize it. It's a normal and expected part of this process. Just avoid any discouragement, demoralization, or judgment that occurs. And it does fall within the harm reduction or minimization approach to substance misuse, because it's not so black and white. It's not necessarily about making sure they stay abstinent for long periods of time. That would be great, but it's more about trying to support them in continuing on. And they may have to restart some of the stages of change to avoid getting stuck at this stage. We really don't want them getting stuck. Just highlighting that it's a learning experience, and if we handle it with care and encourage them, despite the lapse, they may be more resilient in staying on the path of change. A client that is experiencing a lapse may say, I slipped up over the holidays and had a few drinks at the work Christmas party. So that's your opportunity to address that and show some understanding, but also get them back on the path with some encouragement, and maybe even, like I said before, reviewing how they did get there and what steps they were successfully taking. So that is just a review of the different stages. That brings me to what actually is MI. So traditional approaches in healthcare focus on convincing a patient to make changes in their behavior, while motivational interviewing uses a more guiding style to help clients think about the importance of changing their behavior. So it's not necessarily telling them what to do, but having them reflect on why it may be important to them to make a change. Essentially, it's a style of communication that involves the strategic use of questions and statements to help clients find their own reasons for change. You may be familiar with the term Socratic questioning. So it's really in line with that. If you are a therapist who's you're asking questions or making statements designed to elicit some of this motivation and desire to change. It's a person-centered, evidence-based treatment that elicits behavior change by helping clients explore their ambivalence. We said ambivalence is a natural and inherent part of the change process, and we want to meet patients in that space of ambivalence and help them figure out what they're going to do with the ambivalence. So we don't really want to tell them what to do when they're feeling that ambivalent. Again, not forcing the scale one way or the other, but pointing out, oh, you're really sitting with this. What do we do with this? So a more curious approach to that. It's an empathic, supportive, yet directive counseling style that provides the conditions in which change can occur. It hinges on being collaborative and honors the patient's autonomy. And the aim is to support patients in exploring their own reasons for change and strengthen their own intrinsic motivation so change arises from within them, as we talked about before. It can be used as a standalone technique, or a lot of people will complement their already practice of CBT or ACT or DBT with motivational interviewing, just to get clients to act on changes they need to make. It also borrows from client-centered counseling and its emphasis on empathy, optimism, and respect for client choice. What's the basis? We've already highlighted that ambivalence is natural to the change process, and that's a huge basis for MI. And it can be resolved by working with the client's intrinsic motivations and values. And the alliance between the client and practitioner is a collaborative partnership to which each brings their own expertise. The patient is going to know themselves and the reasons why they want to change or they don't want to change, or what keeps the behavior in place better than anyone. So we really need their expertise in the process, but we as practitioners also have expertise ourselves that can help guide them. So what's it mean when I talk about the spirit of motivational interviewing? Motivational interviewing is not a set of technical interventions or manualized treatment. It's more thought of a way of being with a client, and it has 4 elements: collaboration, evoking, autonomy, and compassion. I'll just break that down. So collaboration as opposed to confrontation. So we're going to work together on this. Evocation, just being able to create a space for the client to really feel comfortable sharing more about themselves and their story and their struggle. So you want to evoke as much as you can from the client. And then that gives you more material to work with. Autonomy versus having authority over the client. So you want to show that I value you and respect your decisions. In the end, they need to make their decisions autonomously. The more authority you start imposing, the more defensive people tend to get, and they don't like to be told what to do. So if you can kind of acknowledge that they have their own autonomy to make decisions and self-efficacy in doing so. And then the last one is practicing compassion in the process, just making statements like, I want to understand and respect you and your experience. That compassion goes a long way, especially when they're feeling vulnerable and confused as to what to do with their situation. The 5 principles are really the techniques that we keep in mind when we're practicing motivational interviewing. And it can be thought of as, what we're actually doing in MI. So we express empathy in an attempt to understand the client's point of view. We develop discrepancy to highlight the different aspects of the ambivalence that they're sitting with. We try to avoid argument. Argument usually arises from resistance. So rather than arguing when a client becomes resistant, we want to, what we call, roll with resistance. And I have a lot of examples and suggestions in this presentation for you in terms of how you roll with their resistance instead of butting heads with them in an argument or fighting the resistance. And then we want to support their self-efficacy and making changes as they go. So empathy, it can be defined in a lot of different ways. In MI, we talk about it being a skill for understanding another's meaning through reflective listening, and it requires sharp attention to each new client statement and the continual generation of hypotheses as to the underlying meaning of those statements. So it's really trying to listen and reflect rather than telling them what they should be thinking or what they're feeling, communicating respect for and acceptance of the clients and their feelings, and encouraging a non-judgmental or collaborative relationship between the two of you. Empathy really does kind of promote this supportive relationship, and it allows you to provide more guidance, because if they see you as supportive and knowledgeable, they might be more open to hearing your suggestions on what to do. Developing discrepancy. A lot of times I'll give these examples. So it's working with that ambivalence. We want to open space and hold space for clients to sit in that ambivalence. As soon as we advocate or put our own agenda on, they need to focus on just the change part, we're not really respecting that there's kind of motivations against that. So we want to just very curiously explore that. So hold the space for the ambivalence and put it back on the client to let you know, what are they doing with that ambivalence? So an example would be, so on the one hand, you haven't noticed any consequences of your drinking, and yet on the other, we see your blood pressure has been quite high, which could lead to more serious health issues. So again, you are kind of showing a need for them to change, but you're acknowledging that they see things a little bit differently, and then putting it back to them. What do you make of this? Another example would be, I understand that you've had bad experiences on the pill. I'm also aware that falling pregnant at this time would pose a problem for you. How do you make sense of this? Acknowledging the bad experiences, why they might be rooted to not changing, but also there's consequences, but how are you sitting with this? What are you doing with that? And then another one is, on the one hand, you're coughing and out of breath quite a bit, and on the other, you're saying cigarettes are not causing any of your problems. What do you think is causing your breathing difficulty? So just posing, they're maybe not seeing why those things are connected, but pointing them out. Avoiding argument, like we said, you may be tempted to argue, especially if the client's being really defiant or provocative, but trying to convince the client that a problem exists or that change is needed could precipitate even more resistance. It can turn into a power struggle. And I guess we always want to try to be aligned with the client. So I'll use the phrase walking with the client quite a bit, just to show that when you start to feel like you are sitting across from the client and there's kind of resistance against, you want to figure out, how can we get back on side with the client, and how do I walk with the client through these issues? And that's why kind of acknowledging that there is ambivalence or whatnot, you're really trying to see things through the eyes of the client and offer them space to explore that a little bit more, not just, oh, you see it this way, I see it this way, who's going to win? Again, there's different types of resistance that can come up. Obviously, we mentioned arguing, but there could be a temptation to interrupt, to not allow you to go further in what you're trying to explore with them, denying or ignoring certain things. And if we're to try to deal with those types of resistance, then we need to be able to roll with them. And rolling with them does have to do with what I was talking about before, is it may not be about arguing or advocating for your version of what they should be doing, but again, showing curiosity, pointing out the ambivalence, and maybe just using a lot more reflections. So in the rolling with resistance, there's various types of reflections that we make. The first one is a simple reflection. The client may say, I don't have time to exercise. And instead of trying to say, well, you have to make time, or there's always time, let's figure out where you can make time, it's really just putting it back. Your life is too busy at the moment to make time to exercise. So again, you're not telling them what to think, or you're not refuting the statement. Putting it this way just allows them to elaborate a little bit more. Now, when I've done this with clients, sometimes they say, well, no, I'm not too busy. Like, I do have some things, or yeah, I'm busy, but you're not, they're almost having to pose an argument against that statement that you just gave, but you're not supplying the argument against. Another simple reflection, if a client were to say, I really want to start taking my medication again. You might say, taking your medication is very important to you. It's kind of an affirmation, really. You're kind of affirming that medication is important, and it strengthens that side of the ambivalence that's geared toward change. An amplified reflection highlights something in the statement that they've just given you and almost exaggerates it to the point that the client has to argue against it. So it's similar to what I mentioned before, although the simple one wasn't as highlighted or accentuated. So a client may say, I don't know why my wife is so worried. I don't think I drink any more than any of my friends. A practitioner may say, so there's no need for your wife to be concerned about you. Now, there's probably a lot of reasons why this patient's wife could be concerned, especially if this patient is in your office exploring maybe drug and alcohol issues. The fact that it's even brought up by the client show that there are reasons why his wife might be worried. But simply putting it back on the client to explore is good for them, because then they consider, well, no, there is a need for for my wife to be concerned. She's concerned about X, Y, Z, and it just keeps the conversation rolling. But look how it tips the scale without you forcibly tipping the scale, just putting it out there, and then they have to explore the other side. Other parts of rolling with resistance include using double-sided reflection. So reflect both sides of the ambivalence. Again, those statements that start with on the one hand, on the other hand. The client might say, I know how bad it is to keep smoking with my COPD, but I just don't know what else to do when I get stressed out. And you might reflect, so you can see how smoking can make matters worse for you, yet it has also been a source of comfort, and it's difficult for you to imagine how to manage your stress without it. Just a very genuine reflection that starts to show, I see both sides of this coin. What are we going to do with that? And sometimes they'll elaborate. A lot of times they'll elaborate on why they should be changing, because in the context of your office, it seems the most logical place to take that conversation, but you're not forcing it there. You want to just acknowledge the situation and align yourself with the ambivalent feeling, not necessarily align yourself with the reasons of change. They might get there on their own. Agreement with a twist. So client might say, I can't picture myself not drinking. It's a part of who I am. It's how I escape, and it helps me get through the day. You might say, you can't live your life without drinking. It's such an important part of who you are, and you're willing to keep drinking no matter what the cost. A bit controversial, but that would easily, you're almost tipping the scale, advocating in an extreme way for the reasons why they can't do it. And they might be provoked to say, hey, wait a minute, I'm not willing to keep drinking no matter what the cost. Like, I'm here because I do know I need to improve. But you're making them take the side of the reasons for change, evoking it from them. The other parts of rolling resistance are shifting focus, so aligning and diffusing discord when maybe an argument starts to arise. They might try to provoke you with, what do you know about depression? I feel like a failure all the time. You're a doctor. Everything must have turned out great for you. And again, this is almost a little bit of a personal attack, but obviously with certain clients, we can see that they're maybe trying to ward us away by putting us on the defense of ourselves, or, lashing out so we don't continue on a certain inquiry. But you might just very neutrally say, it's hard for you to imagine how I could possibly understand how much pain you're in and what you're struggling with. So it very much neutralizes, shifts the focus back on, look, this is really about how much you're struggling, not about how life turned out for me. But not saying it that way. Obviously, that doesn't sound very sensitive, but just highlighting, getting back to their pain and their struggle. Reframing is another alternative. So the client may say, I've tried to keep my diet so many times, but I always slip up. So that's a bit of a hopeless statement. You want to try to reframe the hopelessness in that and highlight what they have done and why it's so important to them. So you might highlight, you're very persistent, even in the face of discouragement. This change must be really important to you. Because look, in that statement, they're also telling you, I really keep trying to maintain this diet. I'm doing the best I can. I'm focusing on how much I'm slipping up. But you as the practitioner, not that it's not important to sometimes focus on why are we slipping up, to counteract the hopelessness, you're kind of saying, wow, you're really persistent, even in the face of being discouraged. And it must be so important to you. That just kind of uplifts them to be like, yeah, you're right. I think I can keep going down this path and work with this. Another way of rolling resistance is use of metaphor. So paint a picture for the client. It's a reflection that just kind of summarizes. Client might say, I can't take too much more of this anxiety. And you as a practitioner may say, you want to be in a better place or a better space. Reflection of a feeling, a deepest form of reflection. You're not reflecting back the content of or summarizing what they've said. You're really getting to the bottom of what the felt experience of what they're saying is. So the client may say, if I don't stop drinking, I won't be able to qualify for the transplant and I could die from this. And then you as a practitioner may just attune to the feeling and reflect it back. You're scared. Your drinking could be a matter of life or death for you at this point. Yeah, and it gives them a lot of kind of space to explore that feeling rather than some of the particulars. And being able to bond with that feeling and open space for it may actually foster some motivation to tip the scales over to the change side of things. Lastly, in terms of what we're doing in motivational interviewing is supporting self-efficacy. We really need to believe in our client. You know, sometimes our clients are just so resistant, and as much time and energy that we put into helping them make changes or we offer suggestions, they may not be following through. But you know what, if you lose faith or you don't believe in your client, they're not going to believe in themselves. So really, honestly, before going into sessions with your client, as much as you might be feeling stuck or frustrated, try to tap into what do you believe in them? Like, what makes you feel like they can really do this? And bring that energy with you into that session. And you might notice that it's somewhat contagious and the client starts to believe it in themselves. So optimistic empowerment is engendered in the patient to encourage change. Foster hope and enhance the client's belief in his or her ability to change, and identify the patient's strengths and bring them to the forefront whenever possible. Another version of this is identifying the client's values and showing how certain changes may be in alignment with their values. Some of you that are ACT practitioners are probably well versed in doing that, and that's well within the MI framework as well. So some of the core motivational interviewing skills, we use the acronym OARS. So open-ended questions, affirmations, reflective listening, and summarizing. Open-ended questions facilitate a dialogue that encourages the client to do most of the talking. Affirmations support that last aspect of self-efficacy that I was talking about. Reflective listening, it's really checking in rather than assuming you know what is meant. And we just went through a lot of reflective listening skills and reflections in the last discussion. And then summarizing. A lot of times this happens toward the end of the session. You want to reinforce what was said. It shows that you're listening carefully, and it also helps organize your patient's thoughts. And you can actually strategically summarize in a way that either equally balances the reasons for or reasons not to change. So it really accentuates their ambivalence, or you could even, while you're summarizing, weigh it a little bit more heavily on, here's all the things out of today's session we talked about in terms of your motivations to change, just to remind them, and don't highlight why you think they should change. Highlight and summarize the things that they brought into the session about why they want to change. What do these look like? So I just drew up some examples, open-ended questions as opposed to closed-ended, which are usually like yes or no, or only want or evoke a single word answer, are things like, what brought you in here today? How were you able to stick to your diet for 3 weeks? Tell me more about when that first began. What's different for you this time? What was that like for you? So yeah, a lot of times this just helps them elaborate on their experience. You just try to facilitate further conversation. Affirmations. Some of these are really good to enhance their commitment. Your commitment really shows by how regularly you're coming to see me. You showed a lot of determination in doing that. It's clear that you're really trying. By the way you handled that situation, you showed a lot of strength. With all the obstacles you have right now, it's really impressive that you've been able to maintain your progress. So you can see in all of those statements, it's affirming the efforts that they've put in or the progress that they've made. And these may be used in concert when they're having difficulty seeing hope for the future. So being able to reframe a little bit with some affirmations is really helpful for the client. I might just quickly go through these reflective listening skills. It really shows you more stems that you might use in order to induce some reflective listening. So you might start sentences like, it sounds like, and provide a little bit of a summary or paraphrase what the client has just said. What I hear you saying is, and then those double-sided reflections. So on the one hand, it sounds like, and yet on the other. Another good way to put that is, so a part of you is feeling this way, and a part of you really, and you just kind of explore those parts, acknowledging that, again, it's not a dichotomous variable. They're not either going to change or not going to change. There's parts of them that are kind of at war, and we want them to understand that and make sense of it. But then once they have insight into it, take some action in their best interest. Other stems for reflective listening are, it seems as if, or I get the sense that, or it feels as though. So all ways that you can start sentences in order to create a summary statement that allows them to either confirm, say, yeah, it's exactly that, and then go further, or they might not even agree that much with you. They may be like, well, no, just like we were talking about in terms of if you point out something that they maybe said, but they don't fully agree with because they're ambivalent. And then summarizing. So you want to draw out, this is you, instead of just putting a brief summary that is trying to get them to give you more material. Summarizing in this sense is more giving a holistic summary and almost as a way of concluding and organizing their thoughts. So you draw out the most pertinent points, arguments for and against the change that the client has said. And you might clarify with the client after you've made the statement, is that correct? Have I missed anything? And then they can kind of clarify, and that shows that they're trying to organize their thoughts around it as well. And then once you've summarized and they've confirmed or they've clarified, you could say, so what do you think you'll do about that? And again, it throws it back to them. And sometimes when they do say, I'm not sure, you could ask them permission to give a few suggestions. Say, I might have some ideas. Would you like me to share those with you? So again, it's a very light, sensitive to their sense of agency approach. What are some of the strategies to use within certain stages of change? So we went through the stage model, and we went through some of the the principles, the spirit of MI, and some of the things that we do, the skills involved. So how do we graft those two onto each other? So in pre-contemplation, we want to first and foremost establish rapport. We want that really strong, trusting relationship. Again, when you need to give advice, you ask permission, you ask if it's okay, you don't kind of dominate and assert your authority. You want to raise concern in the patient about their behavioral patterns. So when you may, because they don't see any reason for changing in this stage. So you, instead of kind of harping on these are the reasons you need to change, you can, through your empathy, just express some concern about how they are struggling with certain things. And maybe that will induce a bit of concern or urgency for them to maybe feel the same way or look at it in the same way you are. Contemplation. Again, this contemplation is all about the ambivalence and exploring it. So you want to normalize that the ambivalence exists, and it's up to us to bring it out into the room, hold space around it, and really just look at it from as many perspectives as possible. And then they can make sense of it and move forward how they choose. You want to elicit change talk. Change talk is if we're thinking about that kind of seesaw, the side that is motivated to change, you'll hear certain phrases that allude to, yeah, I'm thinking about change. I'm starting to get motivated toward that area. And we'll talk about how to elicit or encourage change talk in a little bit. In the preparation stage, you're clarifying goals and strategies, you're offering some information and guidance with permission, because they're already showing, hey, I'm thinking about making changes. I just don't know what to do. Like I'm in preparation. In action, they're already making those changes. They're, again, taking actions or behaving in a way that's designed to reinforce change. So you want to just be there to reinforce the importance of changing, and kind of making sure that they recognize the importance of this. In maintenance, you want to affirm the client's resolve and their self-efficacy. And you also want to do a bit of relapse prevention. So just making sure that all the protective factors are kind of in place and that they're aware of the risk factors and they're able to manage those so they don't go into a lapse. Now, if they do go into a lapse, as we talked about before, it's not your job to kind of scold them or tell them what they should have done. All that's coming from kind of the critic voice. We don't want to reinforce the critic because the client's going to be kind of hypercritical of themselves and feel ashamed and down and probably think, what's the point of going on? Instead, you want to kind of embody that healthy adult self that has compassion and understanding and really just wants to get to the bottom of what's the meaning? Why do you think this happened? Try to elicit curiosity, show curiosity and try to elicit curiosity. When they get shameful of themselves, they're cutting themselves off of exploring that any further. They're like, oh, there's no point. I'm just useless. I'm just a failure. It's like, well, no, let's understand this, because those two parts of you are still at work. And the part of you that wants to change was going strong for quite a while, which is great. Let's not forget that. But the part of you that didn't want to change won out momentarily. Let's just understand why that happened so we can get a better idea what to do when this might happen in the future. Really non-judgmental, accepting that this is a natural part of the progression through change. Talked about change talk. So we notice clients are slipping into change talk if they have if they start expressing these different areas. So the desire to change. So if you start hearing sentences like, I would like to, or I wish, or I really want to, that's usually a sign that they're telling you these are the reasons I desire to change. And you might do a lot of reflections back when they start having these types of discussions with you, because the more you spend talking about change, the more likely they're going to take action on it. And if they're the ones that are giving you these nuggets of wisdom, like these pieces of gold for you to work with, don't let that drop by the wayside. Reinforce it, bring it back into the conversation. They might have comments about the ability to change. Oh, you know what? I think I can cut down to 2 glasses a night. That's a good kind of opportunity for affirmation, some reflection, and then maybe some planning. They might, in terms of change talk, be talking about reasons for change. I know my health would improve if I stopped smoking. I would have more energy if I stopped using. So you could make reflections. Yeah, your health is really important to you. And you know you would want it to improve. So, you know, is smoking important, or is it more important to look after your health? Looking at those different things. And then another aspect of change talk is need. I should do this for my children. This is showing I have a motivation to change for my children. It may be different for different people, but again, that's a learning. Don't let that statement just slip by. Again, reinforce it's really important that you do right by your children, or that you're there to be a great dad. And part of you making this change is so you can be that version of yourself, show up to your relationship with your kids and be an amazing dad. So I think that's a great reason to change. It's coming from them, you're just highlighting it. Another part of change talk is when they start to evoke commitment to change. I would like to, or I plan to. This is usually in the action phase, or even in preparation when they're starting to just brainstorm different ideas or reasons why they might need to change. So obviously, as the therapist, it would be beneficial for you to elicit as much change talk as possible. And once you're in a mode of change talk, promote that as much as you can. Because the more space we find, or the more time we are in that space of change talk, the more we are just inherently counterbalancing the reasons not to change with the reasons to change. So eliciting looks like either affirming or weighting the discrepancy in the decisional balance. What are some of the good things about alcohol? What are some of the not good things about alcohol? And while you're managing that discussion, you could intentionally elaborate a little bit more on their ideas around the not so good things, but you don't necessarily completely ignore the good things. It's a good coping skill for me. It has always provided a sense of comfort, you know, and just reflect that that's why it's maybe hard for them to change. But what are some of the not good things? But if you don't give them an opportunity to voice the good things about it, or what's reinforcing it and keeping it in place, you show that you're really biased. Another version of eliciting change talk is an evaluation of their values. So I talked about this before. How is the behavior aligned or misaligned with the patient's values? How do you connect their responses to their core values? This would entail reviewing the client's core values early on in your engagement with them. And as you continue to treat this client, refer back. Oh, that seems to be really aligned with your value for family. Your family don't agree with your substance use. You don't want this to cause a rift within your relationships. So I'm hearing that this change is really important because you want to remain close with your family and you don't want them disappointed in you. And I'm really glad you're living more in alignment with that value and trying to remain close with your family. Sounds really important to you. Another a way to elicit change talk is an activity such as writing a letter to yourself or envisioning 5 years in the future and kind of breaking that down. Having them talk about, if you did make the change that you want to make, what does it look like 5 years from now? What does your life look like? They can kind of unpack in their mind how their life has changed for the better. And in 5 years, they can see the culmination of those changes. Obviously, this is an imaginal exercise, but at least it gets them occupying that space of what would it look like to change and all the positive aspects of that long term. If you're a therapist trying to induce some change talk, I usually use these rulers. They're called change rulers, and they center around a few aspects of what it means to make a change. So usually you need to find it important enough to make a change. You need to be ready to make a change. Even if you are ready, you need to be confident that if you act on those intentions, that you will be able to make a change, like you will be, the ability to make change, and that you'll maintain a commitment. So you can use these at any point in the therapy if you think the client would be either struggling with this and they need to reflect on what it is they need to improve in this area. So let me just give you an example. So in terms of importance, you have them rate on a scale of 1 to 10, how important is it for you to make this change? And then they might say, let's say 4. And most therapists would be like, oh, 4, okay. Well, why not an 8? So why is it not more important to you? Again, that really exposes you for having a bias toward the change aspect of things. Oh, why isn't it more important to you? Can you give me a lot more reasons why, you should be doing more? And look, that has its place, but I think the more strategic place to start would be, why not a 2? So it's important to you at a 4. Why not a 2? And then they're like, well, a 2 is really low. It's not important to me. And they now are the ones explaining why it's important to them. So you're not showing the bias that they should be higher on that scale, but you're inducing the change talk or the reasons why it's important. And the same thing can happen with readiness, confidence, and commitment. So confidence, on a scale of 1 to 10, how confident are you that you can make a change? Again, they could say 6, and you start by saying, okay, why is it not a 3? And they could be like, oh, you know what? I have a lot going for me at the moment. I have a lot of support in my corner. I think I have the tools to change, so I should be pretty confident. And then that's when you might say something like, what would have to happen to make it a 9? Well, I would be more confident if the temptation wasn't there, and maybe I should be limiting some of those factors that tempt me. So again, use these scales strategically. If they give you a number and you ask, why is it not maybe a lower number, you're putting them in a position to argue for the importance, confidence, readiness, or commitment. And then maybe you transition gradually to what would have to happen or what would make it a higher number. But again, it's more from a place of curiosity and only after you've elicited a lot of their own change talk. So I've gone through a lot of material and I tried to be fairly quick so I could fit it all in, but I would love to hear how this is sinking in. And if over the course, since I wasn't able to pause throughout the conversation, if any questions came up or any comments or even criticisms or any ideas about, how does this align with other ways of working with clients, I would love to answer your questions. So I think now we'll just take a little bit of time for some questions and answers.
Thank you so much, Robbie. That was brilliant. We have had quite a lot of questions and a lot of chats coming through, an incredibly engaged group of people who have been here, which is fantastic. Bearing in mind that we have run over time a little bit, we have had some people send in some questions and then say they've had to run out, and that's completely fine. If you're happy to stick around for a few minutes, we can go through those. If anybody else has to leave, please send through your question and we will run through them. And then if you're able to catch up on the recording, you can do that. And alternatively, I think, Robbie, you said that you're having people to contact you with any questions. Is that right?
More than happy to, yeah.
Excellent. Thank you very much. Okay. So first of all, a question from Sandra about whether if a client has poor self-esteem, how do we work on the optimistic empowerment without making them feel worse?
Oh, that's a really good question. So a lot of times, and I was reading the chat a little bit, and people were pointing out that sometimes I do speak in a little bit of schema talk. So a lot of times with low self-esteem, you have kind of a really intense critic that's putting you down. And so as a therapist, you do want to use, because with the spirit of MI, that compassion component is really important. And a lot of times to counteract a really high critic voice, you want to elicit where their inner compassion is. So, again, affirming all the things that they've been doing that are keeping them on track to making these changes, but then having compassion for where they start to criticize themselves and how they start getting down on themselves. So if anyone does CFT, compassion focused therapy, I think it would be good to integrate that if you have someone with low self-esteem, because it starts to bolster that part of them that can see, yes, I struggle, but not the critic part that's saying, yeah, you're not good enough, you'll never be good enough. So the affirmations talking about what they're doing well, but I think the deeper rooting of integrating compassion focused strategies would be really helpful.
Yeah, okay, thank you. I'm just trying to look over all the chat that have been coming through just in the shorter time that you were speaking then. We've had a huge amount of chat that's come through. Maybe, Erin, as I ask the next question, would you just mind having a look through those that have come through just to see if there's any questions that we should be asking Robbie? In the meantime, another question from Sharon, and she has asked, when summarising with clients, some might say, you're the expert, how do you suggest to handle that type of comment, that they are handing us the power role even though you're trying to walk with them?
Sorry, what was the second part of that? So you're the
DOC.
I'm not understanding the question.
I'm not quite sure what Sharon means there. I'm not sure if Sharon's still online. That they're handing you, okay, maybe if we just talk about the second part. So if you're being handed the power role, if you're trying to walk with them.
Yeah, that's a good question. So I try to, at a lot of different points, be very neutral. So you can tell the reflections are not, you're trying to, in a neutral space, reflect back their experience, try to point out the discrepancies in what they're talking about. When we start to make more directive or authoritative comments, it then highlights that power dynamic. So if there's any way that you can start to neutralize that, and sometimes they do look to you and they're like, look, I just want you to solve my problem. I'm sure a lot of the therapists or whoever is on this webinar has that experience of maybe they're kind of desperate and they're like, I don't know, I can't make this change. Why don't you just tell me what to do? And sometimes that can be empowering. Like you think, oh, they're actually going to follow my advice. Or it's actually from a place of, I have no self-efficacy and I don't know, like you just try to solve it for me. And then you might be reassuring to hear advice from, but they actually leave your office still feeling like, I don't know what to do. I'm not strong enough to make this change. So again, I think it's a good opportunity to use some affirmations and reinforce what are the reasons for change and what they have power to do, respecting their autonomy, that they actually are in charge of their life and they have to make their decisions, that you want to explore this with them, that you're their partner guiding them. A lot of times what I'll do is draw on like poster board or a whiteboard or something and just show that like there's going to be this journey. It's going to be non-linear. There's going to be some divots and we'll make some progress, but it's and I'm a horrible drawer, so it's like two stick figures with like some jagged lines, just showing the journey isn't linear and I'm walking with you on this journey. It's not me directing you from the top being like, get up here, why aren't you coming quick enough, like where it's like two stick figures really separated with this huge journey they have to go on themselves. It's more about, here, I'm here every step of the way. And so sometimes you have to use a bit of metaphor or visuals to show, look, we're in this together and you have your expertise. I have my expertise. How do we work this out? What are you going to put into practice? I'll show up and be the best practitioner for you with whatever expertise I'm coming up with. But it's acknowledging we have to walk every step together and we can't look too far ahead because we might get intimidated and scared. So let's just take it one step at a time.
Yeah, I really like that idea. And I like the idea of, this whole model is really about a change in the power balance.
Yeah.
We've had some suggestions of what DOC might be. One is doctor, of course. Another is drug of choice. So I'm not quite sure, really. Anyway, thank you. I think that you answered that really nicely. Another question, and I'm aware there's a lot that I haven't got to yet, but is it helpful to strategically suggest that a person reduces their goals in a more realistic way? For example, only cutting down slowly and gradually rather than attempting to cutting down to 1 glass a night, rather than to say 2 to 3 glasses may be easier.
Yeah, I'm smirking because I get into this conversation a lot with people. I actually challenge them because they'll be almost overly optimistic and they'll be like, I'm just not going to drink this week. And you're like physically that's not possible. They have such a physical or physiological dependence on the substance. Mm-hmm. It's like almost unsafe to just complete. And it's like, okay, well, what's an achievable goal? I always kind of throw back. And if anyone's familiar with the SMART goals model, like sometimes I'll do that. Okay, well, what do you think is realistic and achievable? What time frame are we looking at? And just because you want to make it easier, if they set too lofty a goal, they're going to set themselves up for failure and they'll lose faith in the process, So you want to be like, oh, I love where you're coming from. I think that would be a great goal. That sounds like something we could maybe achieve in a few weeks. Why don't we come up with a couple of steps in between then that are more achievable? Like, what do you think is really achievable within the next week? And not to like downgrade that they've come up with too lofty a suggestion, but actually meeting them in a place where, you're being more realistic, you're affirming the optimism and the motivation that you're seeing, but just being like, from a harm minimization standpoint, like they might even think that you as whatever your role is, drug and alcohol counselor, psychologist, is expecting them to be abstinent. A lot of times we occupy the parent role and then they will start to look to us and say, oh, well, if I needed to answer to my parent, I'd be the good boy. Like, I'll do whatever you want. And it's like, well, no, I'm actually like, we need to figure out what is going to be best for you. So you kind of have to go back into your good enough mother or parent role and be like, that's really great that you're that enthusiastic. What do you think we can actually do? Why don't we just aim for 2 glasses a night? Or why don't we aim for drinking 3 times this week instead of 5 days a week? So managing that where you think they can actually make progress.
Yeah, I think what you mentioned about SMART goals is so compatible with this whole model. It really makes sense.
Yeah.
We've had a few questions about whether there are any good role play videos or examples of MI that you know of.
Oh, I will.
Spot for that one.
Yeah, well, there's a lot of YouTube videos out there. I will say there are some amazing resources through SAMHSA, which is the Substance Abuse and Mental Health Services Administration in the United States. And then the other organization I would direct you toward is MINT, or Motivational Interviewing Techniques, Strategies and Techniques. They run a lot of trainings, and I just, don't quote me, but I think if you kind of YouTube and search motivational interviewing techniques and either SAMHSA, which is SAMHSA, or MINT, motivational interviewing strategies and techniques, you'll get a heap of different things, because a lot of them make their materials open source. Like, I'll say I'm not, I'm not the content expert here. Like, I'm a practitioner. I use it in my practice. I love it. It's a passion of mine. But these people are actually like doing research on it, pumping out trainings, trying to get people informed. So I think they're the subject matter experts that would be good to maybe find videos and guidance from.
Okay. We've still got quite a few questions, but maybe, would you have time for just maybe two more?
Of course I have time.
Okay, excellent. All right. So a question here, and this is a bit of a tricky one, I think, whether you might have any thoughts on a client who may have neurodivergent autism, who seems very fixed in ambivalence, and they rationally understand the need to change, but substance use is a very functional tool for dealing with sensory overload and other things.
That's a really good question, because I've had a couple of people like level 1 ASD or level 2 ASD, and you start to realize where you're hitting a barrier, where you do, there's a separation, because the sensory issues are so intense, the overcompensation almost feels necessary as a coping tool. So look, I think everything that we just presented fully applies. I would almost lean really hard on that compassion part. So if we're talking about the spirit of MI, collaboration, evoking, autonomy, compassion, I think that client probably does still have a lot of ambivalence, and having compassion for that space of, it feels like such a strong need, because the sensory overload is probably more than the normative population or the non-divergent population. But you also struggle with this kind of cognitive understanding of why you should be changing. Like, what is that like for you? Like, I almost want to go back to, what's the felt experience of this conflict within you? What's that frustration? How do you deal with that frustration? How does that frustration maybe make you want to lean more toward changing, or do we want to just understand this better? And maybe with that frustration, there's a bit of compassion for the struggle. There may be very real ways that this person will not make changes for a while. Like, some of our clients are very complex, and they will be longer term clients. So even though I was quoting research that within short interventions, you could have lasting change, we have to be cognizant that some of our clients have either intellectual or neurodivergent or even personality organizations that are going to make their journey a bit longer than others.
Okay. Yep, that makes sense. Another question about, I suppose, maybe more client directed, about a particular client perhaps. Do you have any thoughts about the effectiveness of MI where the client, so when the client has presenting mental issues? So maybe this is, so that's one question, but I think maybe.
Is it about comorbidity? So they have mental health plus substance dependence.
I think that is what the question is asking about. Yes.
Yeah, so I mean, it goes hand in hand. I guess there's a degree to which, if you empathize and connect with the client fully, you'll be doing a lot of reflections, not only on their ambivalence about substance use, but how their struggles with either depression, anxiety kind of contribute to this. Because a lot of times when they are in a really depressed or anxious state, they're not their healthy adult self. And that part of them that doesn't want to change and is really dependent on maybe the substance to auto-regulate is overriding that part of them that is like, oh, don't do that. That's not good for you. And so I guess you got to just show empathy and reflect back how that is a struggle. And again, maybe using some compassion focused interventions to strengthen that healthy adult part of them, to intervene in times where maybe they are struggling, both with mental health, but also the substance issues that are maybe self-medicating their mental health.
And just following on from empathy, there's actually a question about that as well, talking about the latest edition of Moyes and Rolnick, in that they consistently talk about the importance of empathy. And what do you consider some of the important things to remember when relationally attuning to a support seeker with empathy?
That's a great question. I like the way that it was worded. So look, attunement is a really important thing. I guess to diverge a little bit from MI, I like to, my background is a lot of psychoanalytic, even though I'm talking a lot of schema. So trying to figure out where they are from an attachment perspective, like we might have clients that are a bit like anxiously attached or, disorganized attached. So just trying to figure out what are their needs. Like empathy really has to do with understanding what this client is presenting in front of me and what are they saying about what they need in life or in terms of support. So yes, they may say a lot of things that are going on in their life, but it's like, what do they actually need? And they'll reveal bits of that in snippets of what they're talking about. And when you start connecting with their needs and you reflect them back, they feel so seen and heard, and they feel like, okay, I can trust you. You see me for who I am. Empathy also sometimes, if you're comfortable with a little self-disclosure, clients will be comforted if you can say, like, I've had a lot of clients that have presented with what you've presented, that maybe you can disclose a little bit of your personal struggle or your life experience of certain things, because that solidifies, I'm not just someone that went to school and learned a bunch of models and whatever. Like, I have been in the trenches with people struggling with this, or I myself have actually struggled with this. And I know that these techniques are really helpful. And I know that you're probably doubting how helpful they'll be. But let's just take it one step at a time. And you know what? I'm happy for you to contest against me. That's part of the process, and just kind of work with them on that level. So depending on how comfortable you are with self-disclosure, you could make some statements that really solidify, I do understand, this isn't just all academic.
Yeah. And it comes back, I think, to what you were saying before about you're walking with them. There's not a divide between you.
Yeah, absolutely.
And compassion, empathy.
Yeah.
Really nice. And I'm very sorry to everybody out there if I'm butchering your questions. I realize I'm probably not asking them the way that you intended. I'm very sorry about that. You're interpreting them very well, however, thank you. Okay, so another question from Alex. If a client is ambivalent and almost resistant, can it be a good idea to ask why they are at the appointment, assuming that they're not mandated?
I guess if you phrase it a certain way, I think obviously when I first read that question, why are you even here kind of comes off very confrontational. And look, I think there's some schools that would actually use that to get them to provoke them to fight against it. And it is in alignment with some of the MI techniques, but I think we just need to use a little bit of a softer, less controversial or provocative way of phrasing that. Sometimes I'll even just reframe, well, what's important for us to talk about today? Like, what's important to you today? And it just kind of puts back onto them, because you don't even have to say, why are you at this appointment? Like, you're in the appointment and you just have to say, well, what is going to be important for us today? And it almost says it without saying it, if that makes sense.
Yeah. Try to get at it without without the hammer.
Yeah, it's like, well, you're here today. How do we make the most out of this? I know that it was specified, assuming the person's not mandated. Now, with mandated clients, that can be a really big issue is I don't want to be here. So like, and you could even, I've had pretty difficult experiences with people where I'm just kind of like, look, we have the whole hour. We could sit here in silence, or we could make the most out of the time that you have with me. And there's a lot of things that maybe would be helpful to talk about. I could sit here in silence. We could sit here in silence. But I mean, that doesn't sound like much fun. Like, what could be important that we could discuss today? Assuming that, you know, you might be having difficulty broaching a certain topic around substance use, whatever, and they might just start making chit chat, and then you get to the reason that they're here because you're in a context, you know, you're not at a bus stop. So it's just a little bit more, it's easier for them to direct back to the purpose of why they're there.
Yep, that makes complete sense. Another question. Would this technique approach would be relevant to personal relationships as well, or do you think it's more for a professional context?
I think that's a dicey one. I feel like whenever we're trained in psychological techniques, if you bleed that into your personal life, it can get a bit messy. Because obviously you have a certain relationship with people and they're like, oh, don't therapize me, or I don't need to be spoken to that way. I think if you actually handle it from a place of being genuine, like, of course, we have these theories and models and ways that we talk to people that are strategic. Obviously, this whole seminar has been about the strategic use of reflections. I think if you use these things in relationships, you need to lead with your heart and don't slip into your therapist mode, that you do genuinely. And I'm not saying that when you're with clients, you're not leading with your heart, but I think you just need to be really careful using any psychological jargon or techniques when you're in the presence of someone that has, you know, a different relationship with you. And just, you know, you can keep these things in the back of your mind, but I would lead with who you are as a person and your heart before you start integrating some of these things. I don't know if that's a appropriate answer, but
no, I think it makes complete sense. I think, you know, if you have these skills, it might be difficult not to apply them everywhere. So fantastic, but at the same time, trying to keep that divide as well makes sense.
Yeah, and trying to stay away from some of the jargon, just because there's certain things that we as therapists say that are very particular to our industry. And it can be triggering for some people that are in your family or partners being like, oh, that's just therapist you talking now.
Yeah. The last question I'm going to ask is, what if a client's memory, perception, and sense of salience is impaired? How does the I'm having a mental blank.
Transtheoretical model?
Yep, forgot the second part of the Transtheoretical Model of Change accommodate the legacy of thought disorders as a consequence of chronic addiction long after abstinence?
Oh, that's such a difficult question, because I think when there's a neurological...
I left it till last, I think, sorry.
That's okay. Yeah, if there is an issue around thought disorders or a neurological basis or physiological basis, we're not dealing with their rational self, so they lose their rational self. A lot of what we've been talking about almost assumes that they have access to their rational part that has reasons for changing, and that we're trying to create a conversation between that rational part and the part that maybe it's habitual. So look, the techniques are still applicable. You have to accept that. And I think working with anyone that either is not able cognitively to connect, or even because of psychosis will slip out of reality. Anytime we're working with those clients, we still apply the evidence-based practices, but we acknowledge that for that client, there's a level of complexity that we're limited in kind of penetrating through. And in those instances, and if you've read anything about like psychodynamic psychology, they talk about the fact when you are dealing with people with thought disorders or really ingrained personality disorders, you go into a more supportive role. and you kind of use more empathy and compassion and try to walk through that with them. Not putting too much pressure on them to apply all the techniques, but just empathizing with the struggle. But then when you have their cognitive function is right online and they can engage in the therapy, you continue as you can. But yeah, any intervention has limits in that way.
Yeah, that makes sense. Okay. Thank you, everybody. And if we didn't answer your question, I'm very sorry. Again, you can contact Robbie if you'd like to, if we've missed your question. And I'm sorry again that we ran over time. So just before we ended, I wanted to quickly put up the comorbidity guidelines that we mentioned at the beginning, and these are linked to these webinars. You can find out more information about those and our other resources at our website, and also download the slides. I don't know, there's been lots of questions about those, and watch the recording again at this site on screen there. We also have a free online training program, as well as a new face-to-face and train the trainer program on that website there. And thank you again for having joined us for this webinar. If you are interested in looking at this recording again or our upcoming webinars, they can be viewed at the website there. You can also join us for our next webinars. The next one is on the 16th of September, and that will be on building comorbidity capacity in AOD services, followed by one in October on shared decision-making. And in November, we will have one on multiple behavioural change. Until then, thank you again for joining us, and thank you again so much, Robbie. And please, everybody, enjoy the rest of your day and stay safe and well. Thank you.
Thanks, everyone.